Hello, everyone. Thank you for joining this webinar today, which we're very happy to be hosting for you all. I'm Mary Legay. I'm coming to you from the UK, where I work for an organisation called Itad. So for those of you who've not heard of us, we're a global consultancy providing evidence, learning and strategy services to help solve complex challenges. And we had the pleasure of leading an independent evaluation of the Challenge Initiative Family Planning Platform, also known as TCI. So I've been the deputy team leader for the evaluation, which has been running over the last 4 years. And it's been an amazing journey to be part of this evaluation. So on behalf of the whole evaluation team, we're really excited to be sharing our headline findings with you today to help inform how we design future family planning programming and think about how we use data within evaluation. So after a process for us, starting with in-depth methodological discussion, followed by intense data collection, analysis and write-up, here we are today having the opportunity to share our learnings with the wider community, which really is one of the most important parts of the work that we do. And we'd very much like to extend our thanks to the Gates Institute at Johns Hopkins Bloomberg School of Public Health for co-hosting this event with us today. So we've got 5 speakers lined up who I'm happy to introduce. So we'll be hearing from Kojo Loco, who's Executive Director of TCI, Karen Hardy, who was the evaluation team leader, and David Jodrell, who led the impact evaluation component of our wider evaluation. We also have 2 speakers from India today, representing one of the local governments included in the TCI platform and in our evaluation. So we'll be pleased to be hearing from Dr. Jaskaran Singh Gangwar, who's Deputy Chief Medical Officer in Amroha, Uttar Pradesh, and Arsan Ali, who's Urban Health Coordinator in Amroha, Uttar Pradesh. We also have some other members of our evaluation team in the audience who may come into the discussion during our Q&A session at the end. So the structure of today's session is going to start with about 30 minutes of presentation from our panel, followed by the opportunity for our panel to answer questions from the audience. And before I bring in the first speaker, there's just a couple of housekeeping points for me to note for you all. So if you'd like to ask a question that we'll answer in the Q&A section at the end, please can you use the Q&A function in Zoom? Just enables us to keep all of the questions in one place and we can sort them and look at them as we go. So there should be a button at the bottom of your screen linking you to that Q&A function. And as I said, we'll be taking questions at the end once we've heard from all of our panelists. We also have French translation available. So to access this, please click the interpretation button in the menu at the bottom of your Zoom window. And finally, we will be recording this session today, so it will be available to view afterwards. Okay, so I'm now very pleased to bring in our first speaker for today's webinar, who will be Kojo Loco, Executive Director of TCI, and Kojo will be setting the stage for us by providing an overview of the TCI platform. Over to you, Kojo.
Thank you, Mary. And thank you all for joining us today. I'm excited to open this webinar with a brief overview of the Challenge Initiative, TCI for short. So TCI is a trusted platform for strengthening local health systems at scale. Since 2016, we've supported the scale-up of proven high-impact family planning interventions through a distinctive model that is demand-driven and led by local governments. To date, TCI has partnered with 214 local governments across 13 countries in sub-Saharan Africa and Asia, reaching a combined population of 290 million people. This year, we're expanding again, bringing TCI support to urban communities in two additional countries, Bangladesh and Indonesia. TCI is led by the William H. Gates Senior Institute for Population and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health, in close collaboration with our regional hub partners, including JAPIGO, overseeing East Africa, Global Communities, Francophone West Africa, Johns Hopkins CCP, Nigeria, PSI, India, Green Star Social Marketing in Pakistan, Zwilik Family Foundation in the Philippines, and most recently, Sajida Foundation in Bangladesh and Jalin Foundation in Indonesia. Our primary funders are Bayer and the Gates Foundation. And I pay tribute to all our partners out there who have supported this work to create this outcome that we'll be looking at today. We also pay tribute to the cities, the districts, and the provinces and states that we've worked with, the local leaders, the politicians, the health systems. We pay tribute to them in terms of the hard work. So, at the core of TCI is how we partner for scale, impact, efficiency, and long-term sustainability. We work directly with urban local governments. And when we refer to local governments, it could be primarily cities, provinces, states, or districts, with a focus more on the urban locations in there. So we support them to own, lead, and strengthen their family planning programs. So local governments move through a four-stage engagement process, which I'll just go through. The first stage, which is the expression of interest, is where there is the building of awareness amongst these local governments, sparking their interest and assessing their readiness to engage. The second stage, which is the program design, once they have engaged and we're convinced that we can work with them, we conduct a landscaping analysis and co-design solutions to address priority gaps in the local family planning program. The third stage, which is the coaching and implementation stage, we provide technical and management coaching to scale high-impact interventions guided by data-driven monitoring, learning, and adaptation. The fourth and the last is the self-reliance stage, which is our ultimate goal. And in that, we continue to support graduation of these local governments. We offer on-demand coaching and promote peer learning so cities can sustain results independently. This approach that I've described is grounded in 6 guiding principles. These are: we engage local governments through a demand-driven model. That is the first guiding principle. The second, we prioritize near real-time, data-informed decision-making. The third, we build local ownership and self-reliance. Fourth, we provide continuous coaching supported by our award-winning TCI University. The five, we focus on scaling proven high-impact interventions tailored to the local context rather than piloting new ones. And the last, we strengthen existing systems and platforms instead of creating parallel structures. So now to our external evaluation. So we do place a high premium on learning and accountability, and we use rigorous external evaluation to shape the platform's direction. Mathematica conducted a comprehensive evaluation of TCI from 2020 to 2021, followed by a major independent evaluation by Itad spanning 2022 to 2025, of which we're here today to listen to the results. Together, these assessments have generated critical evidence on how a locally led approach can strengthen systems, improve health outcomes, and deliver strong value for cities. Building on these learnings and on our track record since 2016, we're excited to begin the next chapter of the TCI platform, which we call TCI 2030. This new phase runs from 2026 through 2030, and we look forward to continue our work with urban communities to achieve sustainable impact at scale. Thank you. And with that, I'd like to turn it back to Mary for the next part of the program.
Thanks so much, Kojo, for that great introduction to the TCI platform. I'd now like to bring in Karen Hardy, who was the team leader for our evaluation of TCI. So, Karen, can you tell us what the TCI evaluation did? And importantly, did it show impact?
Yes, thank you. Thank you, Mary, and thank you, Kojo, for that great introduction to TCI. And I am really pleased to be sharing the findings of our evaluation. And let me start by talking about our methodology. Next slide, please. So our evaluation comprised an impact evaluation, a process evaluation, and a cost efficiency analysis. And it was designed to address the three primary outcomes of TCI's theory of change. These are increased voluntary uptake of modern contraceptive methods, greater local government self-reliance in the effective implementation of family planning, high-impact interventions, and high-impact practices, and finally, improved efficiency of the TCI platform to provide support to local governments for achieving sustained impact at scale. Next slide, please. So starting with the impact evaluation, Itad employed a rigorous approach that included cleaning health information system data, HMIS data, and selecting TCI-supported LGs with the highest data quality. And this was followed by conducting standard interrupted time series. You can see the start of before TCI on the right, and then the implementation, and for the LGs that graduated, the graduation date and the slope. And so it implied applying controlled ITS when suitable controls were also available. And also we employed covariates for the number of facilities reporting data to HMIS to account for changes in facility reporting over time. The ITS analysis was undertaken for each local government and combined using randomized effects meta-analysis, and results were also interpreted in light of controls and contextual factors to assess attribution. And so the graphic on the right was generated for all the 40 LGs with contextual factors such as reporting issues, supply disruptions, COVID, strikes, flooding, etc., along with concurrent programming that was being undertaken in the LGs from other groups, and these were all factored into the analysis. Next slide, please. Moving to our process evaluation, we started by reviewing data and documents from TCI to get a better sense of the program data being collected, and also just the platform itself. And we conducted deep dives in 12 local governments across 7 countries. And that included, again, reviewing documents at that level to understand what was planned in each of the LGs and the context for each of the local governments. And then conducted interviews with 18 hub staff across the 7 countries to get their perceptions of the TCI's contributions. And then we interviewed in key informant interviews 165 stakeholders at the local government level. And these were health and non-health officials that were engaged with TCI, health facility managers, and master coaches, and a few others, but those are the main groups. And then finally, to get maybe a broader sweep, we conducted an online survey of master coaches, and that was focused on their satisfaction with TCI and the effectiveness of TCI and value add from their perspectives. And the online survey was sent out to about 2,800 master coaches across 201 local governments. Next slide, please. Our other methodology finally was the cost effectiveness analysis, and this is to understand the effectiveness and long-term benefits of the TCI platform. We conducted a cost efficiency analysis linking TCI's costs with net contraceptive users attributable to TCI and taken from the impact evaluation, the results of the impact evaluation. And we also conducted a cost benefit analysis or return on investment of the TCI platform with downstream benefits focused on savings or averted expenditures resulting from averted births due to the increased uptake of contraception. We calculated averted costs on primary education, early childhood immunizations, safe motherhood, which was antenatal care and safe delivery, and use of bed nets to avoid malaria. And this analysis allows decision makers to assess whether the economic and social benefits returns on an intervention outweigh the cost of the intervention. Next slide, please. Now I'd like to move on to the key conclusions and takeaways from our evaluation. Next slide. So we have 6 takeaways based on our conclusions, and I'm going to go through each of these 6. And it was hard to pare down all that we did on this evaluation, but we've pared it down to 6 key takeaways. So next slide, please. So first, we found moderate to strong evidence for TCI impact. You can see on the right that contraceptive users per 1,000 women of reproductive age attributable to TCI. Sorry, next slide. There we go. Thank you. Attributable to TCI varied by hub. And the meta-analysis across TCI showed a statistically significant 1.52 additional clients per 1,000 women of reproductive age that were attributable to TCI. That was a meta-analysis pooled across the 40 LGs. And furthermore, the impact on contraceptive use was detected in 31 of the 40 local governments in the impact evaluation, or 78%, again with variation across contexts. So from this impact evaluation, we estimated 634,000 additional family planning clients generated across the 40 LGs during active engagement with TCI. We say active engagement with TCI because the dates all varied, so it wasn't possible to say between X date and Y date because it varied across the LGs. Next slide, please. Next, our cost-benefit analysis showed positive rates of return on TCI's investment. A downstream benefit of TCI's investments was saving local governments on primary education and healthcare. You can see that the $41 million spent by TCI in the 40 LGs yielded an estimated $50 million in downstream cost savings, with positive return on investment in every region. So in addition to donors, this information can be useful to encourage local governments to sustain and increase their own financial contributions for family planning. Next slide. So we've all heard a lot about the business unusual model and the value that it adds, and stakeholders across the deep dives LGs saw the focus on the local ownership, with LGs being supported to lead the design and implementation of programming, as extremely important and appreciated and different from other support they'd received for family planning. And the master coach model, which includes technical and managerial coaching that embedded in the local health system to ensure sustainability beyond TCI support, was also particularly appreciated. Next slide. So a health official in Nigeria shares his perspective on TCI, saying TCI's approach is different. They don't choose or force interventions, activities on you. There's an engagement process where the state jointly sits with TCI to develop a work plan that is in alignment with what the state wants. Next slide, please. Next, and this probably won't surprise anybody on this webinar, context really matters. Our evaluation really reinforced that context matters, and that health system challenges that aren't unique to TCI but face all programming are really important to consider. And these include financial constraints, particularly at the local government level, leadership changes, and health workforce turnover. And very importantly, commodity shortages. All of these affect local government's capacity to sustain the gains that have been achieved. And commodities were particularly important. For example, in one country, supply chain collapse directly undermined contraceptive uptake. And this was even in the context of TCI concurrent with other partner support, tried to provide support, but it still highlights that supply challenges are really a critical barrier. And again, just to reinforce that all of these challenges are not unique to TCI, but need to be taken into consideration. Next slide. So Kojo talked about high impact interventions and high impact practices, and there were 7 deep dive local governments that had graduated. And so you can see here that of those 7 that graduated LGs, some have confirmed that all or most hips and highs have been continued, whereas some, particularly in Africa, said some have been reduced or even discontinued. They noted that political support and integration into the local program was said to facilitate continuation of the high impact interventions and practices, but the resource constraints, and particularly those practices that are resource intensive or that rely on community actors that need to be paid stipends, those were the most at risk of discontinuation in the long run. Next slide, please. Stakeholders agreed that TCI's emphasis on data for decision-making was one of the hallmarks of TCI. And I just want to provide a few examples that stakeholders said about their capacity in this area, including increased capacity for data analytics and visualization, enabling real-time monitoring and also increased ability of providers and district teams to interpret and act on the data. And finally, the support for data for decision-making leading to increased local ownership of the data. You can see this quote about improved record keeping, which may actually also improve reporting from facilities to HMIS, which is a good thing. And just very interestingly, although TCI did not work directly on supplies, TCI's support, again, in this area of data for decision-making, to better data management, reporting, and utilization, they also linked to supply chain management. And stakeholders said that they see this support as having contributed to commodity security by improving commodity needs forecasting and thereby contributing to reduced stockouts. Next slide. So our final takeaway, putting all of this together, is that while the IE focused on contraceptive use and improving use of modern methods, the TCI's overall success should be judged on more than just gains in modern contraceptive use. And that based on the LGs included in the evaluation, we found positive effects on the enabling environment for service delivery and long-term financial returns to local governments. So TCI falls in the category of other interventions that strive to improve what WHO calls, we've all heard of these, the 6 building blocks of a health system, only one of which is service delivery. So by strengthening local ownership, improving data use, enhancing provider skills, and fostering supportive policy environments, TCI aims to create durable change. Next slide, please. So before we move to hearing from our colleagues from Amroha, I just wanted to put sort of set the stage by sharing our IE findings from that local government. And they were from their active involvement with TCI was from 2018 to 2021. And in their 31 months of active engagement, the IE estimated a statistically significant increase of 1.7 clients per 1,000 women of reproductive age that were attributable to TCI, which translates into 100 additional clients added each month, or over 3,000 clients over the engagement with TCI. And also you can see in the graph that this growth continued after Amroha graduated before the end of, and that they added 8,500 additional clients by the time the IE finished, and that was November 2024. So Mary, going to hand it back to you for the next speakers.
Thanks so much, Karen. Good job at squeezing so much work into a 15-minute slot. I know it's really difficult, so thanks so much. And so having ended there with a spotlight on some of the findings from Amroha in Uttar Pradesh, we're really pleased now to bring in two speakers from Amroha. So we have Dr. Jaskaran Singh Gangawar, who's Deputy Chief Medical Officer in Amroha, and Arsan Ali, who's Urban Health Coordinator in Amroha. They're going to be sharing some experiences of being part of TCI and their reflections on what contributed to a successful partnership.
आप सभी को नमस्कार. Amroha is a growing city with diverse needs. Like other urban cities, population is increasing in Amroha also. There are a lot of challenges in health services for urban poor. Our collaboration with TCI India changed family planning services. In January 2018, Amroha entered into a partnership with TCI India. At that time, NUHM was in initial phase. Multiple programs were running, and there was a limited focus on urban family planning services. Our partnership improved urban family planning services and overall health system. TCI India introduced high impact interventions such as weekly FDS to ensure the availability of family planning UPSCs on designated days. Training was given to all urban ASAs for counseling eligible couples. We strengthened convergence between departments and promoted the use of data for decision making. Government of India in 2018 had introduced two new contraceptives, Antara injectable and Chaya oral contraceptive pill. TCI India supported us quickly roll out these new contraceptives. Over the time, UPSCs gained popularity because of trusted services and delivery points. This also helped to reduce the high client load at DCH Amroha. We integrated family planning services at UHND. TCI adopts business unusual approach to ensure scale up and sustainability. For the first time, master coaches were established within the government health system. These coaches were our own officials who helped an important role in implementation. TCI India supported us in planning program, implementation, and utilization of budget, placing demand for additional funds. Several interventions like FDS, ASA in a meeting, SAS Bahu Beta Sammelan are now our part of our planned PIP. We strengthened our data monitoring system, timely and error-free reporting through HMIS, improved both consistency and quality. logistic management were reinforced through FPLMIS to prevent stocks out. Regular review at district and facility levels ensured accountability. The RAISE tool helped us our self-evaluation and helped us to develop action plans for improvement. Amroha graduated in February 2021 from TCI's direct support, but nothing has stopped. Every high-impact intervention continues today. The HMIS indicates that annual family planning clients are now continuously increasing. TCI India built strong technical and managerial capacities and created leadership within the system that has made Amroha self-reliant with pride. Thank you everyone for your patience listening. Thank you all.
I am Ahsan Ali, Urban Health Coordinator under NUHM and a Master Coach, also Amroha, India. It is a great pleasure for me to share the impact of TCI India in my city. With TCI India, Amroha has transformed into a city where family planning is not just a service but a shared responsibility. What made TCI India impactful was that we led the implementation of its HII tools, while TCI provided technical support from behind. They assist in gap analysis, structured planning, follow-up, and timeliness in every initiative. Our journey began with a city consultation workshop, which brought all key stakeholders together at one platform. Through detailed gap analysis and strategic discussion, we collectively developed a comprehensive city action plan to accelerate urban family planning services. With TCI India support, implementation happened step by step. One of the most impactful areas was strengthening UPSC for family planning services delivery. We started with one facility, identify gaps, and introduce FDS to ensure regular family planning services. The results were significant. Encouraged by the success, we expanded FDS to all UPSCs. Today, 100% UPSCs conduct weekly FDS sessions. Capacity building of frontline workers, especially urban ASHA, was another major focus. We guided them for maintaining UHIR, preparing eligible couple dual and understand the process moreover, with TCI India technical guidance, we ensured PPFP in health facility where delivery service were available and the impact reflected positively in HMS data. Use of data decision making were central to TCI India's approach. We use the D4D tool in two ways. First, regularly reviewed HMS data to track trends and family planning uptake. And second, we monitor commodity utilization data at facility and ASA level to plan logistics effectively through the FPLMS portal. With TCI support, Amroha activated the Triple C platform, where representatives across departments jointly address gaps with special emphasis on improving family planning services delivery and demand generation. We are also established quality improvement and data validation committee at UPSC level. As a master coach, I adopted TCI's lead, assist, observe, coach model. The structured approach helped transfer knowledge effectively to health workers. For me, TCI University remains a valuable resource platform. Today, Amroha has become a model city of playground where other districts visit to understand successful implementation. When TCI expanded to Jharkhand, I was part of their mini university workshop, share my field experience and help accelerate their implementation. We are now scaling TCI India intervention to lower performing rural blocks by focusing on PPFP and FPLMS system through virtual coaching. Today, I can confidently say that TCI India has added long-term value to Amroha. TCI did not create parallel structure. Instead, it powered existing system through its initiative, and that is why it TCI impact in Amroha continuing. Thank you.
Thank you so much for these fantastic insights, which I hope have really helped to bring some of our evaluation findings to light in one of the contexts in which TCI operates. So you'll have heard mention there on use of HMIS data within program monitoring. And this provides quite a nice segue into our final speaker for today, who's David Jodrell. So David led the impact evaluation component of our work evaluating TCI. As we heard from Karen at the start, this used HMIS data for rigorous quantitative analysis. So we'd like to ask David to share his reflections on using HMIS data for evaluation in this context. Over to you, David.
Could we move to the next slide, please? Great. Yeah, hi everyone. So this little bit change in tempo, maybe from a more programmatic reflection. But at the start of this evaluation, Itad and TCI posed a question of the extent to which HMIS data can be used for rigorous impact evaluation. And I'd like to quickly go through 3 key learnings we've had on doing this work. I think the first thing to mention is that TCI provided an evaluation challenge for Itad, 214 local governments, 13 countries, wildly different contexts. So in achieving this, our first learning really is that HMIS data can be used for rigorous impact evaluation of global family planning programs at scale, but only if deliberate design choices are made. Now, the scope of TCI that I just mentioned meant that basically primary data collection was out of the question. Just too much, it would cost too much money. So in terms, we were tied to health management and information systems data, namely family planning statistics in that data. And we really found that there was a range of design choices we needed to make to get this evaluation to work at scale. And 2 of them I wanted to surface today, I think, because they were critical. The first being that the actual methodological choice we used offered us some real advantages. So probably a bit of a shout out to ITS as an analysis method. Now, one of the major advantages, and hopefully you can see this from the graph, and Karen already explained this, but the pre-intervention data, so data pre-TCI in ITS, can be used to project what would have happened if TCI hadn't been implemented. And in this graph, that red squiggly line you see at the bottom, that is the projection. The blue line is our observed data. So the difference between the red and the blue line is effectively TCI's treatment effect, actually what happened versus what we'd expect to happen without TCI. Now, this approach, one of the major advantages is the counterfactual comes from the same population. So it comes from the local government population, which means we don't need controls. One of the big findings from the first evaluation of TCI by Mathematica was controls could be found, but not in all locations. And from our analysis, we actually found around about half of our LGs, we found a suitable match control. So ITS allowed us to expand impact evaluation, attributional impact evaluation to the whole sample. The second thing that I'd like to mention in terms of getting this working is really that we used an approach which accounted for the nature of health data. So our analysis method used something called REMA models, or autoregressive integrated moving average models, a bit of a mouthful. Basically, what that means is it's an approach which can take some of the noise out of the data. So seasonality, correlation, months predicting months in terms of service use, very common in health data. This approach smooths some of that noise out and allows us to find TCI's impact more clearly. But we also were very, very serious about the data quality of what we looked at, which takes me on to my second point, which is when you're doing impact evaluation at scale using secondary data, you need to balance coverage with rigor. Our approach, we prioritize the 40 LGs that Karen's described to you and the results that Karen described to you prioritized internal validity, internal rigor of the analysis, which meant we had quite stringent data inclusion criteria. But it also meant that those that we included, those 40 LGs, we spent a lot of time cleaning the data, building the models to reflect the reality of operations on the ground, and then using that information to interpret the attributional confidence for each LG. And as you can see here from our example from Pfizer, we've got a mapping of several things in here which are real, like health worker strikes, like COVID, or data reporting artifacts like seasonal strikes because spikes because the Indian government have more days in March for reporting than other months. So that led us to have a very robust picture of a small number of TCI sites. But what we did to build on that for TCI is we actually took this initial analysis we're reporting on today and we automated it. We made it completely computer-driven, minimal researcher involvement. Now, what that allowed us to do is for the LGs with slightly worse data quality, we expanded the analysis out. So we had an additional 95 LGs we haven't reported on today, but that information has been given to TCI for their own internal monitoring and program performance work. Now, that then poses the question of if you can do analysis like this almost free, i.e. automated, do you need the rigorous researcher-led impact analysis? And the way we tested that is we simply took the 40 LGs we've reported on today and rerun that automated analysis and looked at the difference in results. What we found in general was actually the portfolio level findings were relatively agreed pretty well. So TCI overall, TCI next gen, TCI phase 1, general patterns were fine. What we started to see difference were at the hub level, and those differences were expected. So it was hubs where we'd seen data challenges or strange structural patterns in the data. Where we really struggled with the automated approach was at the high level of granularity. So when we were looking at individual LGs, in some of those instances, the results changed by 100, 150%. So what does this mean for people who are looking to do this type of work? Well, it probably means that if you think about automated analysis, it probably has a place. There's zero marginal cost. Once you set up the analysis, you can add new LGs, new countries, almost for zero cost. And it seems to be very good at giving you broad direction. So how's the portfolio performing overall? Is there any areas to worry about for future evaluation? The final point in terms of the rigor happens at the granularity. So when you're doing impact evaluation where you need to make programmatic decisions, rank performance between different LGs or different countries, that level of rigor and attention to detail is required. So HMIS data is absolutely able to deliver rigorous impact evaluation. It's able to do that at low costs with researcher involvement, and automated can get you at part the way at partial answer to that, but not a full answer. Yeah, I think I'll stop there.
Thank you, David. Some complex stuff to be trying to squeeze into a 5-minute slot in a webinar, but hopefully that gave folks a bit of a kind of flavour of some of the learnings that we've had from this quite interesting part of our methodology. We have about 15 minutes left now for questions. I've been keeping an eye as far as I can on the chat and in the Q&A. So whilst you're with us, David, we have one question directly for you that I'll start with, and then I'll move on to some of our other questions, which are a bit more general. So if you could just try and keep your answer, David, with quite brief, so we can move on to some of the other questions. So we have, the question is the automated data cleaning available to external researchers? And what were some of the most critical validation or anomaly detection approaches?
Great question. So the automated data cleaning, so the model development was automated. The data cleaning itself, we use some automated approaches. That code and that IP has been shared with TCI. I think that would be a TCI decision in terms of sharing it more widely. In terms of the data cleaning, I'd say one of the critical things is being very clear on what you can and cannot fix retrospectively. So reporting rates, you're not going to go back and suddenly get service delivery points reporting more in the past. So that should probably become an inclusion criteria for your analysis. Other things which you can fix often around verification. So if you see a massive spike, is that a real thing? Is that a result of COVID, or is it like an issue with the data reporting? So cleaning is really about detective work at that stage, is identifying why it's happening and then implementing an analytical fix. And the approach we use is if it was a real thing, we kept it in. If it was a data artifact, we addressed it analytically, either through the models themselves or for the data cleaning, we changed the data, we went back to the original sources, etc. I think that answered most of it.
Thanks, David. There's a couple more for you while you have the floor.
Cool.
If you could again answer within just a couple of minutes, and then I will move us on to some of the more general questions. So we've got one here. It's a very broad question, so perhaps you can actually just direct us to some resources. Perhaps is how can the quality of HMIS data be evaluated and validated? We'll take that one first.
Yep. So obviously there's frameworks for validating health statistics more generally. I think FT 2030 has one. There's WHO frameworks. Often they deal with slightly different things that we were looking at for the impact evaluation. So the impact evaluation, we were looking for things which could potentially bias results. So as I was saying, like large structural changes in the time series, which were unexplained, things particularly around when TCI starts, because that's a big problem for ITS. And in terms of the quality of data set, basically what we looked at was missingness, coverage, so having enough SDPs reporting out the total population of SDPs for it to be a reliable measure. Duration, obviously we needed enough sample size for the study, and then explaining and correcting those variations, so outliers, structural breaks, so big changes in the time series, etc.
Thanks, David. One last question for you is, do you have age disaggregated impact results for youth clients below 25 years of age?
We do, but we don't as part of this CU evaluation. So we didn't have time to present on it today, but we also looked at TCI's impact on high impact practice outcomes specifically, and one of those was adolescent and youth contraceptive services in Tanzania and immediate PPFP in India. So we looked at those, but in general, of course, what you get with HMIS family planning statistics is it's literally just the commodity. So most countries don't have that level of disaggregation. They just have, we've distributed 30 condoms in this facility this month. So that level of granularity doesn't exist in a lot of cases. It does in some, like Tanzania, who have a very good HMIS system, but other countries not. So for a global evaluation, we didn't look at it, but we did in specific cases.
Thanks, David.
Mary, can I just
Of
interject, and that is to say, and maybe somebody could put in the chat links to a poster that David did on the outline. Somebody asked for more detail about David, what you were talking about with evaluation, HMIS and evaluation. So there's a poster, and also we wrote a very sort of detailed executive summary to try and add more detail of what we've been talking about today. So somebody will put those in the chat for you so that you have access to them.
We also have a blog on this as well, so that would be good.
Oh, the blog. Yeah, thanks. Yeah.
Yeah, great. Thanks, Karen. Thanks, David. There are some more technical questions coming in about the impact evaluation, but I won't take those now, so we can move on to some others. But please do have a look at the resources, which should help answer some of the questions that are coming up. To move us on, I see a question here, which is, in what contexts does the TCI model work best? Quite a general question. David and Karen, you probably both want to weigh in on this one. Perhaps Karen, you can start us off with an answer to this one.
Yeah, maybe I can start. And that is that I think what we found in the evaluation was that there are enablers for sustainability, and then there are threats or challenges to sustainability. So the commitment by leadership, local leadership, including engagement of key government officials, is really critical. Strong capacity building and sustained capacity building is an important contextual factor. Continuous coaching and training. And another one is a line item for family planning in the local budget, because to make sure that and also distribution of that financial resource from local governments, their commitment. But also, I think, as I said, the integration of these practices, high impact interventions and HIPs into the local system, so that they're just part of routine service delivery and routine programming. And then I think I also mentioned the challenges, which of course is high turnover of leadership and staff, and then insufficient funding allocated and distributed or dispersed. And again, can't emphasize enough commodity insecurity. That is something that we all in family planning need to work on together. So thanks. And David, I don't know if you want to add anything, or colleagues from TCI, you probably have some perspectives on this also.
Yeah, thanks, Karen.
Hi, Mary, Hitesh.
Yeah, hi,
just
Hitesh. Come in, please. Yeah. Maybe
want to
introduce
add.
yourself, Hitesh, so we know who you are.
Yeah. So hi everyone, this is Hitesh. I work as Director Programs for the Challenge Initiative program in India, working through and implemented through PSI India. So on the previous question on the HMIs as well, I think while David did answer and Karen, I would like to take it on from a program perspective. And there's a term called POKOK, which means preventing error before it happens. So from a programmatic perspective, what we did is, ensuring proper trainings, and the data validation committees in place. So earlier there were some sporadic examples in case, say, just because of ill-informedness of the staff, sometimes the data was duplicated or maybe reported, because if the client was referred from their community area to a higher order facility, I mean, both the facilities in that case were reporting. It was more of lack of a training or maybe a lack of awareness at certain level. But TCI did strengthen that as well. And so we don't get those cases now. And also in terms of data validation committee at each facility ensures that there's a monthly validation of all the data before it gets uploaded. So those are the things that also help. And subsequently to the question just now on TCI, I think the four tenets of scale, sustainability, impact, and cost efficiency are the basic premise, and the whole program is based on the high impact interventions, which are ensured that they get ingrained and embedded within the system through the coaching model of law, which is lead, assistant, observe, and then ensuring that the master coaches are there so that the results are sustained, as was evident in certain slides that were shown here for Amroha, Firozabad, and others. So I think this is the basic at a very high level. This is the model that ensures that the system gets strengthened while the family planning work is being done, but it also helps in overall health system strengthening. Over.
Thank you, Hitesh. Great to have your insights on this one. David, you have your hand up, so if you could just give us a quick 1 or 2 minute response, and then I've got one more question before we close.
Very quick, I promise. Just to say that one of the things we did in the ITS, because you had 40 separate sets of results, we could look at factors which determined the bigger impacts versus the smaller impacts that we observed. Karen kind of mentioned this earlier. We didn't find much prediction from baseline characteristics, so like MCPR at baseline, baseline method mix, so LAMPs versus short-acting methods. Where we did see effects were disruptions, so commodity disruptions, political disruptions, floods, etc., that seemed, particularly early on in the program, have quite a drag on the treatment effect, but later in the program mattered less. So there definitely is the role of context seemed very, very important in this evaluation.
Thanks all. I know big questions, short answers. One question that I'd like to bring up now is one we had around cost. So I'm hoping that Scott is on the line to take this one. So Scott led the cost effectiveness component of our evaluation. And the question is, why wasn't there a stronger return on investment given global norms that often cite as $120 for every dollar spent? Are you with us, Scott, to take that question?
Yeah, I am, Mary. Can you hear me?
Yes, we can.
Yeah, good. So, yeah, that $120 figure, which is from one of the other studies, is really, I think, in terms of cost-benefit analysis of family planning, a real outlier, because they put practically everything, put the kitchen sink into that one. Our cost-benefit analysis was rather limited to the elements that were described, mainly children's education up to grade 6 or 7, health interventions or health immunizations for young children, safe motherhood and bed nets for malaria prevention. So the benefits part was rather limited because we wanted to focus on short-term returns, which I found in my advocacy work in family planning makes a lot more sense than in some of the longer term sort of evaluation impacts that people sometimes use. So that's why we got those lower returns. The other thing is that the cost element, which is the denominator in a benefit cost equation, were higher than the usual service delivery costs. Service delivery costs per client tend to be around between $5 and $10 a client, whereas our cost effectiveness came out to be between $25 and $30 a client. That's simply because of the nature of the TCI program. Although the impact evaluation that David described does focus on contraceptive uptake, as Karen said many times, the program is much larger in terms of its outcomes than just contraceptive uptake. So it was a combination of higher costs and measuring fewer benefits. Thank you.
Thank you, Scott. Just to introduce who that was Scott Morland, who led the CEA component of the evaluation. We're right at time, so I'm afraid there's not time for any more questions. So I'd like to close today by saying thank you so much for making the time for joining us. We hope you've enjoyed the session. It's given you some food for thought with regards to understanding both the impact of the TCI platform and the experience of the program. If you'd like to read more about our evaluation and get into some of the detail, we've just posted some links to some of the various outputs that we have available. So please do have a read. And thanks again. So wishing you all a wonderful day or evening, wherever you are in the world. Thanks so much, everybody.
Thanks, everyone.